Hello everybody, this is Dr. Jenkins and we are back. So this is our last unit if you really think about it. We did all those intro chapters and then we talked about bones, muscles, and joints. That was kind of one unit. And then we did a unit on upper body, shoulder and elbow, wrist, and hand. So here we are with the lower body. Now, of course, we're going to have 3 chapters for the lower body, starting today or whenever you watch this, with the pelvis and hip. Then we'll do the knee, and then we'll do lower leg, ankle, and foot. So, similar structure to our previous lectures on a joint in a body region, only now we're focusing on the lower body. Okay, so you can see if you're following along in the notes, we have characteristics. So let's see here. So we talked about the shoulder, because remember, the shoulder is the joint that connects the arm to the body. And now we're going to address the pelvis and the hip. Let's first focus on, well, actually both, to be honest with you. So now we're looking at what attaches the leg to the body. So they have that in common, attaching a limb to the body. When we looked at the shoulder, we talked again and again and again about how it didn't have very good stability. If you remember, I keep driving it home. Hopefully, maybe by the final exam when you get this multiple choice question, hopefully it's going to be an easy one. Oh yeah, I got it. Shoulder, poor stability. It's got that really shallow glenoid cavity on the scapula and not a very big head of the humerus. So not a lot of stability or strength, but what we gain from that is a lot of range of motion. Because it turns out we can benefit from more range of motion for our arms to reach things, to do all sorts of fun sports and activities. The hip and pelvis is pretty much the reverse. I'll change colors just to make it more emphasized. The hip and pelvis are both very stable. And I think this makes sense. Why are the hip and pelvis more stable? Well, because of where they're located in the body, they do more weight support. I mean, the shoulder really just has to attach the arm to the body, and that's kind of it. There's not a lot of weight bearing. But the hip and pelvis, they've got to support the weight of the body. They got to support the weight of the trunk, the head, the arms. So that is the one big reason why it has to be more stable. Supports the weight of the body. That's pretty darn important. As a result of having to have more bony structures touching and articulating, we have less range of motion. But you can't have your cake and ice cream too. All right, so we've established that the hip and pelvis are both very strong in terms of bony structure. As we're going to find out, they have better ligamentous support than the shoulder. However, because we have more stability, it does have the one downside of less motion. Just like your notes there. Okay, so in this chapter, we're going to start with the pelvis. In this video, my goal is to get through the pelvis and the hip and get through a lot of the bony anatomy and the ligaments and all that. So when we get to lab, we'll be able to dive into the muscles. And then when we meet again for lecture in person, we can do more of the load analysis and all the rest. So here we are, following the notes, Roman numeral 2, the pelvis. So let's first just identify what the pelvis is. The pelvis is 2 identically shaped bones, sometimes called innominate, sometimes called os coxae. But there's 2 of the same, just in reverse. Together they form the pelvis. And the pelvis connects with the lower part of the spinal cord, which is the sacrum. And the little tailbone or coccyx is down here. So if we're looking at the pelvis together, The pelvis tends to be the red arrows here, but I don't want you to forget that the pelvis, those two halves are connected to each other in the front here. But let me circle that, right? The two halves of the pelvis are connected in the front, the pubic symphysis. But the pelvis, the two halves of the pelvis, are also connected right here to the lower part of the vertebral column, the sacrum. Okay, you can, right, so just to be clear, folks, I really want to try and be clear. If we want to identify what the pelvic girdle is, we've just done it, right? So it is composed of the two halves of the pelvis, and then how it articulates with the sacrum. I suppose we could add the coccyx in there, which is your tailbone. It's not really a direct articulation, but it's attached to the sacrum. So the pelvic girdle would be the pelvis and how it articulates with the sacrum and coccyx. You can read through the functions there. Just like we mentioned already, the idea of the pelvis is to attach the leg to the body. And of course, all those wonderful, the things that you love palpating in labs so much, I'm sure. All those wonderful bony bumps and projections are sites of muscle attachment. The pelvis has the added functions of protecting internal organs. In the female, serving as the birth canal and protecting the developing fetus. It does allow us to have some motion at the hip joint so we can, walk. But also the big one there is supports weight of the body. So make sure you're reviewing all of those. So definitely much more responsibility, many more functions here at the hip and pelvis as compared to the shoulder. Okay. Just pause for a drink there. Thanks for being patient. So let's talk about the pelvic anatomy. We've already established that the pelvis has two identical halves. Here's what each half looks like. This is more of if I look here, this is more of a lateral view here on the right, and this is more of a medial view. And I know it's a little bit fuzzy, but I'm going to help by writing in things by hand here. Hopefully this is a review of the anatomy. So each pelvic half, or innominate, has three regions. So the top region that I'm marking in red here, it is called the ilium. It's the superior region. Some people say it looks like an elephant ear. And then if we go towards the anterior, what I'm coloring in green is the pubis or pubic region. You can say pubis or pubic either way. And let's do blue. And then the posterior region is the ischium. This should be a review. If you need a refresher, go ahead and make sure you're reviewing often. So the ischium is the posterior, it's more on the back, whereas the pubis was more on the front. The pubis was anterior. Okay, and we can see that here. So the ilium was the part in red. Posteriorly, that was blue, wasn't it? Posteriorly, we have the ischium. And then anteriorly, we have the pubis. And you'll notice the ilium kind of takes up the entire top region. It's the biggest elephant ear there. Ilium is the big region. And then the ischium and pubis are more inferior, with the ischium being the region posterior and the pubis or pubic region being anteriorly. So these two halves join together. Each side is called an innominate. Where they connect, and we're going to talk about this later, forms a joint. So one of the joints we'll be discussing is the pubic symphysis, and that is the joint where the two pelvic halves come together. All right. We are going to be discussing some of the specific bony processes in lab, but let me point them out now. Might as well be specific here. Here's what it looks like. This is a posterior view of the pelvis. It's kind of cool. All right. So let's talk about some of the structures, the bony processes. So some of these we're going to be able to palpate in lab. And as I've been saying all along, I really hope that this is a way to help you with the anatomy. It also hopefully can make it feel more applicable. You know, it's like, oh, hey, I feel that right there. Maybe it can help you better understand where it is in the body if you can feel it. So if we're looking at the ilium, one structure of the ilium, so remember the ilium is this whole upper region, kind of elephant ear-esque. One bony structure. So if you're following along in the notes, you might want to, we're under letter B, bony anatomy. Number 1, 3 regions, and we're starting with lowercase a, ilium. So maybe you want to fill in there. There's 3 bony structures that I'm going to point out, and we're going to be palpating all of these in lab. So along the region of the ilium, one particular bony structure I want to point out is the iliac crest. That is this top crest. It's the crest of the ilium, hence the word iliac crest. Where that comes to a point anteriorly. So right here. And you can feel these. These are the front knobs. You can actually feel the iliac crest. It's almost lateral on your hip there, above your hip. If you feel that iliac crest and come to the front, there's a ball. And that is the ASIS. I hope this sounds familiar, folks. And of course, just saying ASIS is not enough. We have to know what it stands for. Anterior superior iliac spine. It is the anterior superior portion of the iliac spine or crest. ASIS. Posteriorly, so if we come to this picture, again, we're going to be looking only at the, I missed some. We're looking only at the ilium there. So we already established on the front, we have the anterior superior iliac spine. On the posterior aspect, the top bump posteriorly, well, if the front one was the ASIS, or anterior superior iliac spine, then on the back part, that back upper bump, is the posterior superior iliac spine. Great sites of muscle attachment, and we're going to be palpating these to do some measurements, actually, in lab. So it's not only going to help us understand the anatomy, but we're going to be able to use it to take some measurements and, for example, look at leg length, look at SI joint position. So for the ilium, please review those 3 bony structures: iliac crest, ASIS, and PSIS. Now let's switch gears to the ischium, which we've been using green to represent. That's the region lower and on the back. One portion I'd like you to know about the ischium is the socket. In the case of the hip, what's going to form the hip joint, the socket is called the acetabulum. The head of the femur is going to fit in there to form the hip. The acetabulum is a deep socket, unlike the glenoid cavity of the shoulder. Sometimes people have an easier way to remember how to spell that by pronouncing it acetabulum. So if you want to pronounce that in your head just to help you with spelling, that's fine. Just to let you know, it is pronounced acetabulum. And the way that I remember that is it's close to your ass, so acetabulum. The other structure of the ischium, I'm going to use the other picture. The other part of the ischium is the ischial tuberosity. This is the big bump. And the ischial tuberosity is a site of muscle attachment, but it's also the big bump that we sit on. Here it is again, ischial tuberosity. We can see a side view of the socket or the acetabulum, but that big posterior bump. And you can actually palpate this. In lab this week, we'll be using a self-palpation method since you have to kind of palpate through your butt cheek. But this is what we sit on. It's the bump we sit on, ischial tuberosity. So two bony structures in the ischium. The acetabulum is the socket, and then the ischial tuberosity is the bump that you sit on. And then the only thing I want to point out on the pubis is what I've already introduced, so I will just remind you. I just want to remind you of the pubic symphysis. This is a joint where the two pelvic halves connect. Pubic symphysis. Technically part of the pubis bone. You would have to have the two halves together because the pubic symphysis is the place where the two pelvic halves connect. All right. So I'm going to move pretty quickly through this next part. You don't need to know any of the specifics. I think you already know this from A&P. I certainly hope so. Of course, the male and female pelvis is structured differently. And, we haven't really talked about this yet in terms of bony structure. The humerus, that's pretty much the same between men and women. It might be bigger in size overall in a man because men are usually taller and bigger. But it had the same structure: head, greater tubercle, lesser tubercle, deltoid tuberosity, medial lateral epicondyle, capitulum, trochlea, etc. But one of the two places, our skull, has some unique differences between male and female, and the pelvis is the biggest. So here are some examples. So if you're looking at this, on the left would be the female, and on the right is the male. Of course, the differences are all about childbearing. You don't need to know the specifics. Here's the information if you're interested, but you don't need to know that. Specifics. Just know a general. The female pelvis has a wider opening to fit the baby through. That's why females have wider hips, because the pelvis is wider and because the femur attaches to the pelvis. The male has a narrower opening. The male pelvis is actually taller up and down in this view. Typically, they have to support more weight. But it's really all about childbearing. The female pelvis is adapted for childbearing. And then the male is more about supporting a bigger frame. All right. We are moving right along. So, joints of the pelvis. Let's first talk about the SI joint, or sacroiliac joint. We are going to discuss the pubic symphysis and, of course, the hip, which people have some idea about. But the sacroiliac joint, it's a really important joint, and if I'm guessing, you probably didn't discuss it at A&P. So this is kind of fun to talk about. Once again, I think it's fun, but you may not. As the name suggests, sacroiliac, this is the joint between the sacrum and the ilium of the pelvis. This is where the pelvis and the bottom of the vertebral column connect. We can identify the articulation points posteriorly. So if you're looking on the right, this is a posterior view. And we can also identify its articulating surfaces anteriorly, right? So these are all the articulating. It's a pretty decent size articulation. So in terms of articulating surfaces, we don't need to get more specific. We can just say it is the joint between the sacrum and the ilium of the pelvis. This is a synovial joint, and it is a gliding joint. Gliding joint. It's a type of synovial joint. We don't tend to think about it. So it's a synovial joint, more specifically a gliding type of synovial joint. We don't usually think about this as a synovial joint because it doesn't have as much movement as the hip or the shoulder, but it has all of the characteristics and structures of a synovial joint, joint capsule, articular cartilage, surrounding ligaments. It just doesn't have a lot of free motion. So as a gliding joint, what type of motion does it have? A little bit of gliding. So it's a synovial joint, gliding. Movements allowed. So there is some gliding motion, but in terms of how much gliding motion, I'm going to put a question mark. This is a case where there seems to be a little bit of disagreement. Some practitioners, some anatomists will believe that there's a little bit of more motion here. Others will believe that there's very little. What we can agree on is that it is a synovial joint because it has all the synovial joint structures, joint capsule, articular cartilage, surrounding ligaments. We can all agree on the fact that there's some gliding motion. But what is unclear is how much gliding. Is there little to none, or is there an appreciable amount? That's probably the two camps that people tend to fall in. Little to none gliding motion, or little to very little, or appreciable. Not appreciable that you can see with your naked eye, but appreciable that it's enough to actually talk about and maybe even assess. So in lab this week, we're going to see if we can see some of this gliding motion at the sacroiliac joint. Now, of course, during childbirth in a female, there's definitely some gliding motion, so no one is going to doubt that. But I tend to believe in the camp that there's appreciable movement here. Not a lot, but enough to actually be worth talking about. Okay, supporting ligaments. So we collectively call them the sacroiliac ligaments. Isn't that lovely? So we're going to call them, it's the sacroiliac joint. So we're going to call the ligaments that surround it the sacroiliac ligaments. There are an anterior band, there's a posterior band, which we can't see from this view, I don't think, and there's what's called interosseous. Do I have a posterior view? I sure do. Posterior SI ligaments, and then interosseous. You should be able to list those. Just be able to list them. Anterior bands of the SI ligaments, posterior bands, and interosseous bands. So there's a lot of ligaments. It's not as easy as, the elbow where you can say, oh, it's the ulnar collateral ligament, and it's a more specific couple bands, or the ACL of the knee, that's just one band. This is more complicated. We got a whole bunch of ligaments. There's a lot of articulating surfaces. So we got ligaments, and if you can look here, they kind of run all the way down. They cover the bones as they articulate all the way down. Okay. FYI, the anterior is a little bit thinner, the posterior is thicker. But overall, just know the three different bands that collectively make up the SI ligaments, and they're pretty darn strong. Anterior bands, posterior, interosseous. That was joint number 1. Joint number 2 is the pubic symphysis, the joint where two halves of the pelvis come together. So the joint is formed by two halves of the pelvis coming together. What type of joint is this? This is a cartilaginous joint. I love it when things come together. Cartilaginous joint. Excuse me, little allergies on this cold Sunday evening. So think back to the joints chapter. We talked about 3 types of joints: synovial, cartilaginous, and fibrous. We've been spending most of our time on synovial joints that are more freely moving. Synovial joints have all those characteristics: articular cartilage lining the end of the bones, a joint capsule, surrounding ligament, synovial fluid. But a cartilaginous joint doesn't have any of those things. The cartilaginous joint is when two bones are connected with a piece of cartilage in between the bones. That's why it's called a cartilaginous joint. That piece of cartilage is a piece of fibrocartilage, so you can see in your notes, fibrocartilaginous disc. So what type of movements occur in a cartilaginous joint? It gives us a little bit of give. So it's not even gliding motion, certainly not flexion, extension, abduction, adduction. The reason we have that cartilage there is just a little bit of give. In this case, we want to be able to have a little bit of give. So every time we step down and there's weight bearing down on our pelvis, it can absorb the shock of that. So another function along with a little bit of give would be shock absorption. Certainly when a female is giving birth, we want to have a little bit of give and expansion ability there. Okay, pretty simple there. All right, so when we look together at the pelvis, so we've just identified two joints of the pelvis, the sacroiliac joint, where the two pelvic halves connect with the sacrum and coccyx, sacroiliac joint, SI joint. And then we just talked about on the front, we have where the two pelvic halves come together to form the pubic symphysis. Individually, there's a little bit of motion at each. So the SI joint has a little bit of gliding. How much, we can't really agree on, but a little bit of gliding, the SI joint. The pubic symphysis has a little bit of give. It's not even a synovial joint, it's a cartilaginous joint, but it has a little give to be shock absorption when we have the weight bearing every time we step down. So those are the individual motions at those two joints. However, if we look overall at the pelvis, these joints can work together for some overall movements. And these are more functional, but this is different from the shoulder. You know, the shoulder had all these kind of random joints working together, but at different times. So if you remember the shoulder, you know, one way to think about it is that it's more of like a kinetic chain. And depending on how you are moving your arm, at what degree of motion, how much force is being, you know, the shoulder can do so much. There's so much motion that you're basically calling on different motions at different joints at different times. For example, if I'm doing shoulder abduction from the arm being at my side, only out to 90 degrees, down there, I'm not really using my scapulothoracic joint very much at all. I'm not really using my sternoclavicular joint very much. However, once I have more overhead motion, I certainly am going to rely more on the scapulothoracic joint. So at the shoulder, we utilize motion from different joints at different times. But the pelvis tends to act as one unit more or less all the time. Acts as one functional unit pretty much all the time. So it acts as one functional unit. So all the parts kind of work together all the time versus the shoulder where different joints were having different amounts of motions at different times. And we don't really need to get that fancy because functionally, you know, what can our pelvis and hip do? It's not really that complicated. You can look at your notes there, pelvic movements. We can do a forward or anterior tilt. We can do a backward or posterior tilt. We can do so these are two pictures of an anterior or forward. You can use either terms, anterior or forward, posterior or backward. And then we can also do a lateral tilt. If I do like a side bend, that's a lateral tilt at my pelvis. Or we can rotate it. So we can do some type of pelvic rotation. But that's really it, folks. All right. Do I have? Yeah. So let's talk about this. Let's skip down to number 2 there. Motions at the pelvis are often secondary to motions occurring at the lumbar spine and hip joint. So much like the upper extremity, it's not just one joint. So these 3 are identifying. So right now we've just done the anatomy of the pelvis, right? The 2 halves of the pelvis, how it connects to the bottom of the spine, sacrum and coccyx. But of course, the motions at your pelvis are interdependent. They all work together with your lumbar spine and with your hip. So motions at the pelvis are often secondary to motions at the lumbar spine and the hip. They all work together. Because in truth, these motions are relatively small. They're observable, but certainly not as much as my hip motion. My hip can abduct much more than my pelvis can tilt. So these are smaller, but when we tilt our pelvis, it's usually happening along with my hip motion. So I've got an example for you. This is an example I would like you to know. You don't need to know the other examples. So if you're wondering, these are here are 4 examples of how these joints work together. Usually when there's a forward tilt at the pelvis, we also are having hyperextension of lumbar spine and slight flexion of the hip. You don't need to know all these specifics. But let's go over one that I would like you to be able to define. Okay, so let's take a really simple example of hip abduction. So if the hip abducts, we know that hip motion, abduction, would be to move the leg away from the body in the frontal plane. In order to really get the most out of hip abduction, so here we have hip abduction of the hip. When that is happening, in order to really get the most, we're also going to have a lateral tilt of the pelvis. That's pretty simple, folks. That's all I'm saying. When I abduct, there's going to be a lateral tilt. There's also might be some anterior rotation at the pelvis. There also might be some lumbar spine motion. So it gets more complicated, but I think this is the simplest example. Think about it. When I abduct, that's the right hip. See, look at me. I should read my own notes, huh? This is the person's left side, right? That's their right. So if I abduct this side, there's going to be a lateral tilt at the pelvis, and that's what these dotted lines are trying to show you. But if you just, stand up and do it right now, when you abduct your left hip, you're going to be able to maximize your amount of hip abduction with a lateral tilt at the pelvis. Easy example. All right, what are some supporting structures in and around the pelvis? So before we get to the hip here, we're still talking about the pelvis. There is a structure called the inguinal ligament. This is basically, it's this white thing. It's basically in your underwear line. So if you think about the crease of your underwear, the inguinal ligament is right there. It's actually really an important structure. It actually goes from the ASIS of the pelvis. You don't need to know this, but if you're wondering, it originates on the ASIS, and it goes to a bump on the pubis called the pubic tubercle, but that makes sense. What are some of the functions of the inguinal ligament? We'll actually have some muscle attachments right to the inguinal ligament. It helps to hold things in. You have a bunch of abdominal muscles kind of right above it here. And underneath those abdominal muscles are your, digestive organs. So it helps to hold things in. As evidence of this, when there's weakening of the abdominal wall, you might have a hernia, abdominal hernia, when part of the part of the intestine comes poking out through the front. That's occurring right around here. All right, there we go. So the inguinal ligament is right here. So a hernia is where you have some of the intestines poking right through. All right, I do want to get through the basic anatomy of the hip joint. See that you can see these bulges shouldn't be there. I'm not trying to gross you out, but I'm just trying to help you understand the anatomy there. Okay, let's talk about the hip joint. So we've talked about the joints in and around the pelvis, SI joint, sacroiliac joint, and the pubic symphysis, and then how the pelvis can work together to move in a forward tilt, backward tilt, lateral tilt rotation. Cool. Let's talk about the hip. So now we're going down to the synovial joint of the hip. This is called the acetofemoral joint, which helps you understand what's articulating here. What are the articulating surfaces? The acetabulum of the pelvis, or to be more specific, the acetabulum of the ischium, and the head of the femur. I love this x-ray because it shows us the nice deep socket, acetabulum. That's a part of the pelvis. And then coming into that is the beautiful head of the femur. The hip joint is the acetofemoral joint, articulating surfaces, head of the femur, articulating into the acetabulum of the pelvis or ischium. This is a deep socket. Unlike the shoulder, we have in the hip, it's a deep socket, which makes it more stable. I'll bring in a model to lecture so you can see. Large articulating surface area. What I want to point out here, some interesting things about the articulating surfaces. So we know that there's a large articulating surface area, but it's not just that. The socket, the acetabulum, not only is it deep, that bony socket is angled. And what I mean by that is it's kind of tilted forward and down. It's hard to talk about it here without having a model in hand. So I'll bring a model when we meet next for in-person lecture. But it's tilted. And what that's going to do is it's going to even strengthen the depth of this joint. So the fact that it is tilted further strengthens the joint. And what we're going to find is that it helps to form kind of a vacuum seal. So along with how the ligaments wrap around it, the fact that it's tilted helps us to have a deeper socket, and it forms more of a vacuum seal. So this baby is strong. If you ever want to go down the rabbit hole, I don't know if you were like me when I was at your place in school, but I guess I'm kind of a masochist that way. It's kind of fun to watch surgeries on YouTube. So if you ever were to watch a hip replacement, you know, in order to go in and do a hip replacement, they've got to first dislocate the hip joint. So, you know, they sedate someone, of course. And after they do that, they literally have to dislocate the hip. And when you watch that, you see how hard it is, because not only is the socket and the joint surface so deep and strong, but because of that anterior and inferior tilt and the way the ligaments are wrapped around it kind of at diagonal angles, and that vacuum seal, they've got to really work hard to pull out the head of the femur. And you can sometimes even hear like a pop because you're breaking that vacuum seal. Pretty cool, as my friend Larry David likes to say. I wish he was my friend, but curb your enthusiasm. Okay. All right. I just came here to get some more space so I could write. What type of joint is this? It's a ball and socket, just like the shoulder. Only in this case, the socket is deeper. So it's a synovial joint, ball and socket. This isn't in your notes, but I would like you to add it. Closed pack position. You know it, baby. The closed pack position is when there's the most bone-on-bone contact of the joint surfaces. Therefore, it's the strongest joint position. For the hip joint, the closed pack position is full extension, which might seem a little weird, but the reason that is so is because of what we just talked about. So because of the certain direction of the tilt of the acetabulum, the way that the ligaments wrap around it kind of diagonally, when you are in full extension, you've maximized bone-on-bone contact and you've really pulled taut the strongest of the ligaments. Excuse me. I think I have a second one coming. Excuse me again. Okay, so closed pack position of the hip joint, or acetofemoral joint, more we can practice with that, the better, is full extension. You already know what kind of movements are allowed. It's pretty much the same as the shoulder. So what movements are allowed at the hip? Flexion, extension, abduction, adduction, internal, external rotation, and then putting all those together for circumduction. Okay, supporting structures. I do want to keep going for a little bit. Maybe we'll go like 10, 15 more minutes here. Excuse me, I'm sorry I had to do that. So let's make some other points about the supporting structures, because this is really, it's a very strong joint. And there's more to the story of what helps to make it so strong. So the articular cartilage, we remember that. Lining the ends of every long bone is a piece of hyaline or articular cartilage. It's kind of like a little glove for shock absorption. Well, when it comes to the acetofemoral joint or hip joint, the articular cartilage is thicker around the edges. So it has regions where the articular cartilage is thicker around the edges. And that really helps the seal, that vacuum seal of these joint. Thicker around periphery, makes it stronger, more shock absorption, but it really helps with that vacuum seal. As a matter of fact, the joint capsule, number 2 there, it does have a vacuum-like seal. It is the strongest anteriorly. You don't need to know that. But the joint capsule, which is what kind of the saran wrap, the thick saran wrap that encapsulates the joint, that's holding in that vacuum-like seal. I think I have to sneeze again. I apologize. Excuse me. I think I have one more, then we can continue. Excuse me. Man, why is it gotta be so cold at the very end of March? This is more like January type stuff. Okay, let's quickly address the ligaments. The first ligament group that we're going to talk about would be the iliofemoral ligaments. As you look through these ligaments, you can see that they're named for the bones they connect. So once you know the bony anatomy, it's going to make your life a lot easier here. I mean, we know that ligaments go from bone to bone, but it's nice and easy here in the hip. So we have the iliofemoral ligaments, a band of ligaments that run between the ilium and the femur. Hence the name iliofemoral ligaments. I'm so sorry. I've already mentioned that altogether, these ligaments, they don't just run linearly. Instead, they kind of run at a diagonal. You see that? These kind of run this way. This kind of runs this way. So they kind of form, even these run that way. So the ligaments run at a diagonal, which in addition to the socket being tilted, really helps to, it's almost like if you were going to form the joint, it's almost like you put the head of the humerus into the acetabulum socket. So if we were building this joint by hand, we would put the head of the femur into the socket, and then we would twist. That's what really gets the added protection in the vacuum-like seal. So these oblique or diagonal running ligaments really help to hold things in. But on the front view here, anterior view, we have a group of ligaments called the iliofemoral ligaments. They're sometimes called the Y ligaments because they form an upside down Y, depending on how you look at it. If we know our anatomy, it runs from the ASIS coming down. Okay. What I want to point out is the iliofemoral are the strongest of our hip ligaments. So, iliofemoral ligaments run between the ilium and the femur. We can see most of them from an anterior view. They are the strongest of all the ligaments. And what their job is to limit hyperextension. So in other words, when you are in hip extension, it pulls these ligaments tight. You're going to hear me use the word taut. I guess it's spelled that way. But so when I say a ligament is taut, it's been pulled tightly. So that's what this ligament, that's when this ligament is stretched, or that's when it's really activated to help limit excess movement. So iliofemoral, it's the strongest of all the hip joint ligaments, runs between the ilium and the femur, and it is pulled taut, or it is pulled on in hyperextension. Also from this view, I'll change colors, we can see the pubofemoral ligament runs between the pubis and the femur. It's a little bit smaller. This is tightest in abduction and extension, so it's really meant to limit excessive abduction and extension, but you don't need to know that. Just know where it is on the front between the pubis and the femur, pubofemoral. And then on the back view, we have the ischiofemoral ligaments. These go between the ischium and the ligament, so this is on the posterior side. The other two ligaments were more on the anterior side. And this is also tight during extension. Not so much hyperextension, but just extension. Perfect. Altogether, these ligaments are diagonal, and that really helps to keep the head of the femur kind of twisted into the socket or the acetabulum. Helps with that vacuum seal, helps with the strength of this joint. Make sure you review the hip versus the shoulder, deep socket versus shallow, a lot of stability versus not. But then when we have more stability, we have a reduction in our range of motion. Also, the ligaments around the hip are stronger, but that makes sense because we've got the added function of having to support weight. Okay, I'm almost done here, so bear with me. There's some other anatomical pieces that we need to address in and around the hip joint. One of them is called the ligamentum teres. You might hear this called the ligament of the head of the femur or the round ligament of the femur. I know this picture on the bottom left is kind of old school, but this is the ligamentum teres. It's a ligament, folks. Let me use red. It's a ligament that runs from the head of the femur into, I didn't mean to make it straight like that. I was reading my notes to make sure I'm trying to be clear with what I want you to know. Let's see. Okay, it runs from the head of the femur to the acetabulum. Runs from the head of the femur to the acetabulum. There it is in that picture. Here it is in this picture. Here it is in this picture. A ligament that runs from the head of the femur into the acetabulum. I like the picture on the left there. It's kind of old school. It's almost like a little umbilical cord. It doesn't have the same function, obviously, but it's like a little cord of ligament that runs from the head of the femur into the acetabulum. It does not contribute to any kind of stability. I mean, it's pretty small in adults. In the fetal skeleton, it does actually contribute to some stability. Helps to hold things together in the fetus, but that's an aside. In adults, it's not about stability. One of the important things about this ligament is that it contains the blood supply. So in that ligament, and that's why I've chosen these pictures on purpose, right? In that ligament is a blood vessel. Look, blood vessel. Look, this little, here's the arterial branch. There's a little blood vessel coming in. So hidden in that ligament that runs from the head of the femur to the acetabulum is a blood supply, is some arteries for a blood supply. And one application to understanding this is if you have a fracture to the head of the femur, you can quite easily sever that little blood supply. Yeah, so if you have a fracture, you can actually cut off that blood supply. And if you cut off that blood supply, it can lead to something called avascular necrosis. Because I'm writing it down, I would like you to know it. I'm checking my notes here. I think it actually might be at the end here. Is it in the end? No. So we're going to add it now. So one anatomical consideration of the blood supply running through this ligament is if there is an injury or particularly a fracture. Because it's actually, if you're going to have a fracture to the femur, it's not likely to happen in the shaft or diaphysis unless there's a car accident or a skiing accident. But a lot of times overuse, like a stress fracture, is going to happen at some of the weaker parts of the femur, which is the neck. If you have a femoral neck fracture, you're disrupting blood flow, which can then disrupt blood flow here. And again, usually bones have very good blood supply, but like we talked about in the hand, the scaphoid, that one carpal bone, if it's injured, it's possible to cut off that blood supply. Well, same thing here. So you could lead to something called avascular necrosis, where you have injury to the femur that disrupts the blood supply going through the ligamentum teres, and necrosis means tissue death. So if you no longer have this blood supply, you may lose blood supply to the head of the femur, and that's what avascular necrosis is. When the bone tissue dies, necrosis is tissue death. bone tissue dies because of lack of blood supply. Sometimes this can happen without an injury that you might quote unquote think of. From my understanding, sometimes it can be somewhat of an unknown cause, but things like alcohol, steroid use can be contributing factors. Just an interesting FYI, you don't need to know that. Two more quick structures. One of them is the labrum. Just like we had an extra piece of cartilage in the shoulder joint, in the glenohumeral joint, that was called the labrum. It was like a ring of extra cartilage, and I gave you an example of that that rubber ring around the rim of a mason jar. Well, we also have an extra piece of cartilage lining the two surfaces of the hip joint, called the labrum, because it's structured almost the same way. Deepens the joint, shock absorption. Deepens the joint, additional piece of cartilage, deepens the joint, even more shock absorption. Within the last 15 years or so, I think as in the world of sports, we're learning more about the labrum. So, for example, back when I was a practicing athletic trainer, we'd see some people that we thought were having chronic hip flexor muscle strains. And what was going on is there was actually a labral tear in the hip. Previous to that, we didn't think it could be really torn that easily because it's such a strong, deep socket. I think, was it Alex Rodriguez that had a labral tear, had surgery on it? So, we're seeing it in athletes now. All right, last piece of anatomy. Oh, yeah, see, look. There it is. Last piece of anatomy is a bursa. We introduced some of these already. Let me refresh your memory. A bursa is a fluid-filled sac. It is located in areas of high friction, particularly high friction. Apparently this afternoon I'm not able to talk and write at the same time, so hold on. Located in areas of high friction, particularly high friction between bony surfaces, between bones. Or I guess bones and other parts. So we'll just keep it at areas of high friction. So these blue things are small fluid-filled sacs. The one that I want to point out is the trochanteric bursa. So we're going to palpate in lab. There's a bony ridge on the femur called the greater trochanter. Well, over top of that is a trochanteric bursa, because think about when you abduct and adduct, there's going to be a lot of friction. Let me change colors here. There's going to be a lot of friction between the bone, the greater trochanter of the femur, and the surrounding muscles. So a lot of friction right there. So in areas of high friction, we have a fluid-filled sac called a bursa. One example is the trochanteric bursa. Reduces friction, can become inflamed with injury. Maybe you've heard of trochanteric bursitis. More common to be found in a runner with this repetitive motion back and forth. That fluid-filled sac fills with more fluid. We're going to end there. We will pick things up with muscles. And have a good afternoon, folks, or morning or evening, whenever you're watching this.